Well, hello, everybody. My name is Garrett Schmidt. I am the managing editor for BBC Exhibit Hall, and I'd like to welcome you all to today's live webinar and panel hosted by Propeller Health, and it is titled Unlocking the Power of Digital Health, How ACOs Can Deliver Value Through Digital Platforms. And I'm really excited to hear from our speakers today. We've got a variety of them, and I think it's going to be a really engaging conversation. A few items of note, some housekeeping things before we get started. Everyone's joined today in listen-only mode, so you don't need to worry about muting yourself or turning off your camera or anything like that. It's a traditional format. Secondly, we are going to be recording the session. And so afterwards, what's going to happen is we're going to send everyone who's registered a link to where you can rewatch and share the session as well as download the slides. And I'll mention that again towards the end. And then finally, we do want to hear from you during the presentation. We're going to have a time for Q&A towards the end. And so, but you don't have to wait until then to ask your questions. So at any time throughout the presentation, if you want to hear from one of our speakers, go ahead and submit your question using your control module. There's an actual little questions area there that you'll want to submit your questions. So without further ado, I'm actually going to turn it over to Ms. Katie Sorens, and she is the Senior Partnerships Manager with Propeller Health, and she's going to introduce our speakers for us. And then I will see you again towards the end. So welcome, Katie.
All right, thank you, Garrett. Hello, welcome everybody. We're really excited to have you all join us today for a great conversation around digital health and how ACOs might unlock the power of digital health to help with their population health efforts. I'm Katie Sorens with Propeller Health. I'm going to go ahead and kind of start off by introducing our panelists. Let me go here. So first off, we have Dr. Meredith Barrett joining us. Dr. Meredith Barrett is with Propeller Health and ResMed. Propeller Health is a precision digital health company on a mission to uplift the lives of every person living with chronic disease. As the Vice President of Population Health Research, Meredith leads the team defining and developing clinical and population health research efforts. She is passionate about leveraging digital health to understand and improve health outcomes for individuals, clinicians, and communities. So welcome, Meredith. Next, we have Dr. Lynette Demare with the Digital Medicine Society, or DIME as they are known. The Digital Medicine Society is a global nonprofit and the professional home for all members of the digital medicine community. DIME Lynette, which is an initiative dedicated to expanding access to high-value, evidence-based virtual first care for patients, healthcare providers, and payers. Welcome, Lynette. And last but certainly not least, from Southeast Primary Care Partners, we have Craig Borland joining us. Craig is the Chief Development Officer with Southeast Primary Care Partners, which is an ACO in the Georgia area. As Chief Development Officer, Craig oversees all population health and business development activities, including payer contracting and value-based care initiatives. He works closely with physicians and other medical professionals to help them maintain independence, enable patient-centered care, and transition to value-based arrangements. So welcome panelists, welcome attendees. I think we're set to have a great conversation today, and I'm just kind of going to go ahead and get us started. And Craig, as our ACO representative, I'd love it if you could just start us off by kind of giving us a little bit of the lay of the land of where ACOs are sitting at, some of the numbers we're seeing on the screen here. You know, it looks like a lot of rapid growth was happening in the ACO area, you know, in kind of the 2012 through 2018, and then it kind of plateaued. Kind of talk to us about what we're seeing. Is growth ticking up, and what are some of those other key figures for ACOs?
Yeah, thank you, Katie. I appreciate the opportunity to be here, and thank you for everybody attending. So if I back way up, just to set the table on what an ACO is, for those who may not be as familiar with the term, it's an accountable care organization. And really what we're trying to do is say the providers are going to be accountable for the total care that they're giving to the patient. It's no longer just the patient comes into your clinic or to the hospital or to the facility and you're paid for the activity that you do to the patient. You're actually paid for the quality and the outcomes that the patient receives. So for me personally, I think it is it's an exciting place to be because it aligns incentives between the funder of healthcare or the insurance payer and the provider of healthcare, and ultimately in that alignment, I think the patient wins. So it's exciting and excited to see that there's been this much of an uptake. So part of what I think you see in the data is the plateau is really related to those ACOs that were coming in around that time. There was some change in policy that required a little bit more quicker on-ramp and aggressive move towards two-sided risk, where previously you could come in and stay in one-sided risk for quite a while. And so that move to two-sided risk is what kind of slowed the growth down. I think what you're seeing, though, is that while the total ACOs may have stayed fairly consistent, the membership within those ACOs are growing pretty considerably. And so you're seeing more and more providers, especially primary care providers, but others as well. We have 750 plus providers in our ACO here in Georgia and Alabama, and about 2/3 of those are specialists. But they all see that there is value to joining an organization like this, to being in a network where they're sharing information back and forth between the primary care and the specialist and the hospital to better take care of their patients. And so you're seeing the ACOs themselves grow, maybe not the number of ACOs grow. And then my last comment here is I think most are probably aware, but CMS has stated pretty clearly that they want all Medicare beneficiaries in an accountable care organization by 2030. So a pretty aggressive move, considering I think it's not even half yet are truly in an ACO. But that's the stated plan, and that's where things are going.
Very good. Hey, Craig, I'm just curious there with the plateau. Did the pandemic, because the timing does kind of align with like the start of COVID, did that play into some of the plateauing there as well? I'm just curious what your take on that is.
Yeah, I think it did. And I mean, as anybody who was in healthcare during the pandemic, you were worried about, getting beds out of hallways, putting tents up to expand your ED, getting the vaccine in, getting tested. So your focus was not necessarily, especially if you weren't already in an ACO, forming an ACO and the kind of the regulatory and administrative burden that can be, as well as there's just so much unknown. You start something new in that period, especially something that can be risky if you're not thoughtful and you don't put the resources in place before you get to two-sided risk. I think it definitely played a factor. What we'll see though is the ACOs, and especially those groups that had other revenue streams, provider groups that had other revenue streams that weren't just fee for service, really did well through COVID, because that revenue continued regardless of whether or not demand was suppressed. So I think we'll see lessons learned from that, and for 23, 24, and 25, we'll continue to see a slight uptick.
Very good. Thank you for that perspective.
Yeah.
The other things when we think about ACOs and growth that I'd love to have you talk about is really, there's been a lot of discussion around ACO Reach that just kind of kicked off this year, or was kind of reworked this year, if you will, and really a focus on health equity. And I think equity is something that everybody knows needs to be addressed. But it feels like now there's some more clear specifics, and there seem to be, more teeth in it, if you will, on kind of how health systems are going to be held accountable and what they need to be doing to address health equity. Can you kind of walk us through that a little bit?
Yeah, really excited about ACO Reach. And just from a personal standpoint, really excited to see a focus on incentivizing providers to go out and serve underserved populations. And even to take it one step further, doing it not in just a way of we're putting a fee-for-service clinic down or an access point down, but we're actually incentivizing provider groups like ours to go and take care of the population as a whole, and to be accountable for the outcomes of how healthy that population is. So I think we'll see this continue. My position is with some of the new proposed rule on the changes to Medicare Advantage, I think we'll see other rules pertaining to Medicare Advantage, because Medicare Advantage and ACO Reach or ACO Reach is the most like Medicare Advantage of any of the CMMI or CMS ACOs. And so I think what we'll see is more incentives to do what ACO Reach is incentivizing groups to do in Medicare Advantage as well. And I think ultimately, you know, in a perfect world, who wins there is the population that's being underserved. So excited to see this. I was excited to see how many groups were interested. They actually had to cap applicants. I can't remember how many applicants there were, but there were a good deal more than these 132. And so far, they've not opened it back up yet for participation in 24, for new participation in 24 or 25. Because I think they really want to see that this works and that it has the desired outcome.
Yeah, certainly a lot of, I think, potential and upside there, right? Like to actually make some key movements in addressing health equity. So now that we've kind of talked about, you know, the landscape, if you will, with ACOs, walk me through from your perspective. You're working every day with these doctors, alongside these doctors. Oops. I think it just went back a slide. Talk to me about some of the challenges that ACOs are facing.
Yeah, and it's the challenge I think I've hit on a couple of times is we're not just responsible now for what happens within the four walls of our clinic or the four walls of a hospital. We're responsible for what's happening outside of the hospital to the patients and outside of our clinic or outside of our hospital. We're now accountable for if that patient is attributed to us as a primary care provider, but they're going to an emergency department down the street 35 times a year because they're struggling to manage a chronic disease. We own that burden. We're financially at risk for it, and I would argue we're somewhat morally at risk for that. When we've told the patient and committed the patient that we're here to take care of you and take care of you holistically, we need to do just that. And so part of the challenge is really how do we access these patients when they're not in our clinics, and that's doing it with robust care teams and support systems around the provider to ensure that we can reach out to the patient and communicate with them and understand what their needs are. But it's also through some of these digital tools where it gives you that consistent data flow and consistent access to the patient, regardless of if they're in your clinic or not. So that's step one, is you're working with a chronically ill population a lot of times, because those, when you look at the second point, anybody who is in this space will say, you know, step 1, 2, and 3 is to stratify your population. If you try to do a one size fits all across, we have 20,000+ members in our ACO. If we tried to treat all 20,000 members the same, then we'd be very unsuccessful. But we really look at where's utilization occurring, where's our opportunity for us to put interventions in place that could curb that utilization, and what populations, what subsets of our population that we're managing would really benefit from those interventions. So you have to stratify it out. And a lot of times those that are at the top and the ones that are utilizing the most healthcare are the chronically ill. So you're working with patients that have CHF or COPD or diabetes, and they're at varying stages of what their ability to manage that chronic disease. So, you know, any tools we can give them, any resources we can give them, anything we can do to help them manage that disease better is incredibly important for us. And it goes to the third point, where it's tough, you know, if they're not in the clinic, or if they're not answering their phone all the time, or if they're not super engaged with their provider, but we're accountable for them, it can be very challenging to reach those patients and understand what's happening. And so we've found in some of the you know, different avenues we've approached, there's some really simple kind of no-brainer things you can do, leveraging, you know, a patient's cell phone, which they have with them. Like all of us, you have your cell phone with you all the time, or leveraging, you know, other digital tools, Bluetooth enabled or cellular enabled tools that allow us to get a lot more insight on what's going on in those patients. And then, you know, information flow is always, if you work in healthcare, you understand, interoperability is still the multi-billion-dollar thing that everybody's trying to understand, and nobody's hacked it yet. So just having that information flow, especially from referral sources or acute care centers, so that we really know what's happening with the patients that we're responsible for, in other healthcare settings, is really important. And being able to get that information and then utilize that information is is a challenge, but there's a lot of good groups out there that are doing that. And then the last, which we talked about a little bit with Reach, is when you look at this data, COVID was a good indicator of this. Their health equity, we have not achieved health equity. There is not parity, and that can be, you can look at it across, you can slice populations however you want, rural versus urban, socioeconomic, ethnicity, religion, gender. You can slice it, and there's inequities at every slice. And so, what I like about the ACO model, what I like about accountable care full risk models, is it's completely agnostic to all of that. If this patient is if you're at risk on this patient, it doesn't matter which of those strata they fall under. It is you're accountable for making sure that they have good, top quality care, and that they are appropriately utilizing healthcare resources and managing chronic diseases, and you're addressing social determinants. So I like, it's definitely a challenge, but it is one of the benefits of these accountable care models, is it really does kind of incentivize the provider to go upstream and take care of patients where they're at in the communities they live in. One quick story on that is, a patient diagnosed with diabetes was struggling to manage their A1C, and we're in the emergency room multiple times a month for that. We did a home visit, and you see, well, they don't have a working refrigerator. And so most of their diet consisted of, foods they were getting from the dollar store or the gas station, something that was non-perishable, ramen noodles, those types of things. And we're incentivized both financially and, again, just kind of on the moral sense. We did buy a fridge for this patient. You put a fridge in their house, and now they're eating fresh fruits and vegetables, and you see ED utilization go through. And the economic alignment for us is that that's shared savings that's being created in this accountable care organization. So, and that doesn't exist in the traditional fee-for-service world. There's no CPT code you can say that I bought a mini fridge for a patient. And so that's one of the really nice things about this model, and especially when we're addressing health equity issues.
Yeah, that's a great story, and I think it really just highlights the ability of ACOs to make inroads with patients by really treating the whole patient, not just the disease, but you're really taking all of those aspects into consideration, and kind of figured out, like, I don't want to say easy fix, but I mean,
right.
that was a small investment that paid huge dividends for both the ACO and ultimately the patient, which is the most important part. So what a great story there. I'm going to pivot. Thank you so much for taking us through all of the kind of landscape and the challenges that ACOs are facing. I'm going to pivot now and have some of our our digital health experts kind of provide point of view and talk through maybe how digital can help overcome some of those challenges. So Meredith, I have outcomes up here, and I'd love for you to walk us through what we're seeing. Obviously, when it comes to accountable care, you can't just be delivering care really efficiently. You have to have that quality side. So there's a lot of things up here on the screen. Talk to us about some of the research that Propeller Health has done and where you've been able to make really good strides in quality, the type of quality care being delivered to those chronically ill patients.
Yeah, absolutely. And thanks, Katie, first for organizing, and happy to be here. And also thanks to Craig for that great overview of ACOs and the potential there. It's really exciting. And I wanted to start kind of from a digital health industry perspective, because I think evidence generation and demonstrating these claims and these outcomes is so critical for digital health as an industry. We have to prove that it works first to be able to build trust and then gain that clinical adoption as well as more widespread coverage. So I think it's really important to show not only that it can work in studies, but also that it can work in the real world through real world data as well. So this has been evidence generation has been a really important part of Propeller's journey from the beginning, and we have focused on clinical and economic as well as patient engagement outcomes in our peer-reviewed research. And we've done this through a variety of studies as well, through randomized controlled trials as well as through real world evidence. So I'll speak to some of the outcomes that we have today in asthma and COPD. So, and I think importantly for ACOs, Propeller has demonstrated significant reductions in costly acute events, including emergency department visits and hospitalizations. So a 35% reduction for COPD and up to a 57% reduction in asthma. And then kind of supporting this evidence too is our other clinical outcomes, kind of more daily lived experience by the patients. So we have a number of studies demonstrating reduced rescue medication use, or SABA. You'll see it listed as SABA. That's a medication that people are taking when they're experiencing symptoms, and it can also be an early indicator of future worsening or an oncoming exacerbation. And so we want to see a reduction in that use. And we've demonstrated significant reductions in SABA use over time in both asthma and COPD, and then also an increase in the number or the frequency of days without SABA use. So that's an outcome that we like to look at because we think it kind of demonstrates it's like a symptom-free day. And so it demonstrates a little bit more of that lived experience of the patient of a day in which they didn't have to use their meds and they didn't have symptoms from their asthma or COPD. We have also focused on controller medication adherence. That's obviously a really important self-management behavior and links directly into quality metrics such as the HEDIS asthma medication ratio, and has been very clearly documented to tie into asthma control, for example, as well as utilization, so reducing that acute utilization. Interestingly, as we saw acute utilization like ED visits and hospitalizations go down, we did note a small corresponding increase in outpatient visits. I think that's really interesting because it does indicate that the patients are being shifted towards the right place, the right primary site of care, as opposed to then waiting too long or not getting the intervention early enough and then showing up in the ED. So I think that's an important indicator. But overall, we do see an estimated just over $1,300 in an estimated annual cost savings per asthma patient, and $3,200 for each COPD patient per year. So that's the quick overview. I actually wanted to kick it back over to Craig. From your ACO perspective, how does that kind of resonate with you, especially with regards to some of that reduced acute utilization?
Yeah, it's exactly what we're going for. So I come from a hospital background. This is not a anti-hospital, but I think the more we can keep the patients that don't need hospital services out of the hospital, the better it is for everybody, and including the hospital system, because oftentimes these are the patients that you really, when you look at it, there's not a margin on these types of admissions or these diagnoses. So at the end of the day, it's a win-win-win from a financial standpoint, but most importantly, a win for the patient and their families who are not having to deal with the hospitalization. And I think the key point here from an ACO is at the bottom right-hand corner of that slide. And again, speaking on the financial side, and I tell people a lot, I use the shared savings or the financials as a proxy for quality of care here. And so if we're reducing utilization, we're increasing the quality of care. And that's the hypothesis there. So, but the savings, that's our revenue as an ACO. That savings is what we're able to then take and invest back into our providers, invest back into additional resources to better take care of the population. So anything that has a savings of $3,200 per patient, especially on a diagnosis this is prevalent as COPD, is going to be something that's very attractive to not only our ACO, but should be to anybody who's at risk.
Lynette, do you have anything to add from your perspective and what you've seen, what DIME has seen with some of their partners?
Oh my gosh, so much. Meredith, thank you for this data. I cannot underscore enough the importance of this evidence data. And I was just at the ATA, American Telemed Association meeting, and I really noticed a tone shift around, we're moving out of this, the innovators that will take it on because it looks cool, new, to people that are really, early adopters still, but really want to see, okay, how do we deploy this for the right populations? Where's the evidence and that it's really going to improve not only our bottom line, but health of patients? And That spans from virtual care models all the way through to regulated products. And I know we'll talk a little bit more about the physician deployment side and their perspectives, and I'm eager to hear from you, Craig. But when I think like what we need to deal with as an industry in the digital medicine is all the news we're hearing about sort of the ethics and equity piece again. So I think about deploying these tools out to a homogeneous population. These data look great, right? But when Craig's sitting there thinking, well, you just told us, Craig, about just the massive amount of personalization that you need in every different population, whether it is accessibility, do they have broadband, do they have safe access to connectivity, do they have the digital literacy that they need to use, the tools, that varies dramatically through educational attainment as well as language and culture, right? And then, do they want to use their data plan? They may have limited minutes that they want to apply. So if they're using a hotspot, is that safe, and does that expose their data potentially to risks? And so, I just am hot off taking the DIME ethics and digital medicine course. And so it's like really fresh in my mind that we can't regulate out all risk. And if we did, especially like around privacy, then we wouldn't have the beauty of the data sharing that we need to make these great leaps in managing patients. So it really starts to think about, okay, well, how can we educate the patients, make sure that all these different populations have what they need to engage? And by the way, engagement sounds like something that a patient wants to do. Really what we're doing is honoring the way that they are living their life and want to interact with us, right? So how do we start to build that in by design? And I think that trust issue that you both mentioned is huge. And so I believe in us as an industry that we will solve for this and design this in. But I think that's where a lot of the change comes in. But I mean, on this slide right here, the idea that we need to personalize at the individual level sounds great, delivering fridges and whatnot. But I think that's where I really want to hear from Craig about, okay, what's working really well with your populations? What do they love about this? And then where is that lift of personalization maybe, becoming overwhelming, and what can we do about it, both from digital medicine, AI, all those pieces.
Yeah, thank you, Lena. It's a good question. We have not had a patient or population of patients come and say, hey, this is too personalized yet. So I think there's a lot of room for us to continue. In fact, we get the opposite, not only as an ACO, but more just as a primary care provider of, hey, I feel like I'm kind of just coming in and being, run through the process here, and I'd like to have more time with my physician. And the physicians are saying, I'd like to have more time with my patients. And so we still have a lot of room to grow there. I think just, personally as a group, and then as an industry as a whole. However, there is some level of, and you said it best, there's a level of trust that has to be created before a patient lets us in their home to tell us, their weights every day, or their blood pressure every day, or, if they are asthmatic, how often are they using their inhalers, and are there correlations between, when they need to use a rescue inhaler and something they were just doing in their life. And so, it's really where I think we need to focus, is building that initial trust that this is something that's good for you. Everybody, if you look at the news today, everybody's concerned about surprise billing and getting all of these, and we've done it to ourselves, because we're trying to manage a business on very small margins most of the time, and so we are trying to capture all the revenue that's out there, not to negatively impact the patient, but if the insurance companies want to pay. So if we've created this dynamic now where the first question that's typically asked when we hand a patient some sort of remote monitoring device is, well, how much is this going to cost me, and when do I get a bill, and those sort of things. And so we've got a long ways to go there, and that's a huge challenge, especially when we talk about digital medicine, and how can we. It's better for the patient, it's better for the insurance company, it's better for the provider. So how can we minimize or just completely mitigate the patient's responsibility in this, because long term we know it's going to be a really positive thing. So I don't know if that answers your question.
No,
but
it totally does.
kinda,
And I know when we talked before, we, you know, you're caring for primarily Medicare patients,
Yep.
and there was this sort of myth. There's so many different digital divides, but you know, is the myth that older adults can't use digital technology or don't want to. And I think that we're seeing, you know, certainly younger people are more willing to share their data and more, you know, facile with technology. But tell us about maybe how you're seeing that play out and what you do to accommodate the different needs. Because I mean, I see the data, but I'm curious,
yeah.
like the boots on the ground perspective is so important.
I can tell you, we have not seen in our limited data set, we have not seen any correlation to older Medicare patients and their lack of willingness to engage with technology. There is a lot of correlation around socioeconomic access, you know, and then kind of education, and the ability to access the types of technology we need them to access. But from an age standpoint, that's not the case. And just anecdotally, I mean, ask a grandparent how they kept up with their grandkid during COVID, and they did it on FaceTime or they did it on Zoom. And so this is not a foreign concept to them. And if they were resistant to it prior to 2020, they learned very quickly, because that was how they were able to communicate with the office. So from a telemed or a, you know, engagement from a mobile platform, no real concerns from a age standpoint on a technological divide. What we have had to do from a technology standpoint is learn, you know, within certain populations or with, and this is spread across socioeconomic and then also education, is the types of devices we're asking people to interact with, or even the apps within those devices we're asking them to interact with. There's varying degrees of using those apps and participating in those programs, if we're not thoughtful in, you know, bringing this to so a younger population, I wouldn't have thought this, but we have some Medicaid, some dual eligible patients that have been brought into our ACO. A lot of them are younger, and a lot of them have special needs. But interestingly, we have one provider who is very focused on that population, and a lot of her panel is focused on that. They interact with Snapchat really well. So we're trying to figure out, like, how do we leverage these apps that they're already using to help them make healthier choices? We haven't tapped that. We haven't figured that out yet, but it was just an interesting insight.
I heard the same thing. Like, Snapchat is near ubiquitous in certain cultures and populations, and you know, and I think that there's other platforms. So I think what you may be telling us is that, you know, the vendors that you work with, you select them very carefully, and that tech support, like designing in access, things like that. And I know if Catherine and Meredith, you guys, from your perspective, have done an incredible job. Sort of some data earlier that is across the board, but how do you support those populations?
Yeah, and Meredith, oh, sorry. I was actually just going to toss it to you, because I think we have data on like patient satisfaction when it comes to digital health, correct? Could you talk to that a little bit?
Yeah, I definitely want to talk to that. Just to sort of jump on the previous points, I think that were really important. And I think basically distilling it down to, you have to use kind of multiple modalities to communicate with patients and make it useful for them in their lives. And whether that's a person or a phone call or a text message or Snapchat or what have you, or a push notification in an app, you have to do kind of that like information gathering early on to see what is their preferred way of communicating, and then use those channels. And I think that helps quite a bit. That's worked quite well with our older populations. You know, we had some initial concerns around our COPD population, which tends to be older, lower socioeconomic status. We definitely see increasing, you know, adoption of technology and comfort with technology. And so, but we pair that for some of the people who have with less comfort with a wireless hub, so they don't have to even think about the data transmission, and then also with a kind of a layer of personal support like a welcome call, and then tech support to make sure that everything's working. And we've seen, you know, similar to what you mentioned, Craig, our older patients actually have the best adherence. So they are, engaging and also making those behavioral changes and do really well. So it's, yeah, we can't use those expectations to guide those experiences. But kind of shifting gears to the quality and the satisfaction piece of it, I think, pulling all of these things together, the communication in the right modality, but also I think in Propeller's case, we've seen that the combination of the hardware, so the passive monitoring with the sensors, which then means the patient doesn't have to keep a record, they don't have to remember for their next visit, it's automatically collected. And then that shows them trends, and we've heard a lot of feedback that that's really helpful for when they go into their next doctor visit. They don't have to remember and kind of think back to the last 3 to 6 months. They have a record of it and they can discuss that with their provider. And so we've definitely heard stories of that helping with shared decision making and just getting to better treatment options that align with their goals as well. So we've had a number of studies where we've measured patient satisfaction via surveys and have found high satisfaction in terms of both the device and the ease of use, and then also the value of the information for managing self-management. So in asthma, 99% reported either being satisfied or very satisfied with the sensor, and 90% found the reports useful. And similarly in COPD, about 84% of patients reported being satisfied or highly satisfied with the information as well as the ease of use of the sensor.
Yeah, and Meredith, if I could add a comment to that, I think from an ACO's perspective, patient satisfaction has become such a big part of how you are graded within the ACO, and definitely on the Medicare Advantage side as well, that we're constantly talking about how do we improve the overall, the level of satisfaction that our patients have with the services they receive. And what we found is it's not rocket science, but you give them more services. You provide a better value to them, and their satisfaction goes up. So 100% agree. And I think that the more in touch we can be with that, it's only become more and more important as patient satisfaction becomes a larger and larger piece of how ACOs and provider groups are graded in these programs.
Yeah, and I think that, like you said, patients, grandparents have been talking to their kids. They expect those digital, it's starting to become an expectation almost, those digital options, because they are so familiar with it and they're using it. My mother-in-law, who I would not describe as tech savvy, figured out how to download Lyft and how to schedule a car so they could come pick her up at 3:30 a.m. and take her to the airport. And so, my husband and I didn't want to get up at 3:30 a.m. But we were kind of worried, like, is she going to be able to figure this out? Hey, when there was a flight to Hawaii on the line, she totally was able to figure that out. So I think folks are definitely able to handle technology and are using it in so many other different avenues that it's natural for them to expect it in their healthcare and as part of their everyday life in that capacity as well. So the other side of the coin, when we think of patients, we got to think of the clinicians. And Meredith, you talked a little bit about the shared decision making and the data. Can you kind of expand on that a little bit more? And what are the data sources that are coming in, and how can they be considered an enhancement for clinicians versus like, oh, another thing I have to look at or go do because they're already so busy in a day? Can you kind of walk us through that a little bit?
Yeah, absolutely. And in the asthma or COPD context, I think it really comes down to it's that passive sensor monitoring. So then it's very easy to be able to monitor both the medication use, so the rescue medication use, which can be that indicator of worsening, and then also the controller medication adherence. So that kind of self-management behavior that can help improve control over the long term. Both of those data streams are really important, but to everybody has been talking about burnout in terms of just too much information. And so Propeller has done quite a bit of thinking through, especially through some of our EHR integrations, where we're trying to figure out what is exactly the information that a provider needs in order to make a decision. And I think the two primary questions that they'll have is, does this patient need acute intervention? Do I need to reach out to this patient now because of an indication of worsening, or does there need to be a treatment adjustment? So should I be switching their meds because of either improving control or decreasing control? And those are some of the really critical questions. I mentioned the EHR integration. I think that's super critical to provide the information and the insights to the provider in the systems that they already use, so that they don't have to do a lot of screen switching back and forth. And that just makes it so much more efficient and impactful. And then everyone has the same information in the record that they can then make treatment adjustments with. I think, you know, the treatment adjustment is one really important piece, and then the early intervention, I think, is the other really critical piece for providers. And we've seen, you know, that increasing use of SABA use of that rescue medication, that can then trigger one of the kind of frontline providers to reach out to that patient, whether it be through a text message or a phone call or an email or what have you. And then, you know, if the symptoms worsen or something else changes, there's an opportunity for kind of escalation of care to the right provider. So that's been one of the most successful implementations at Propeller, is having kind of a layer of care managers who are able to do that more daily or more regular monitoring of a dashboard. And then in those escalation moments, in a worsening event, for example, or a need for treatment adjustment, that can then be escalated up to a physician, for example. So then that kind of gets, you know, the right patient, the right treatment by the right provider, which can help with some of those efficiency issues.
I think that's great. Along the same line of that, like right treatment, right provider, Lynette, I'd love your perspective, because I know you guys have done some work on kind of the care continuum, and when does somebody need to go from primary care to specialty care? So, you know, Meredith, you're looking at it in a particular clinic and the support staff helping that physician, but then when that patient does need to maybe, you know, be referred out, can you talk to me, Lynette, about some of the ways digital health has helped enabled those kind of care transitions and that seamless referral and coordination?
Yeah, that's a good one, right? That's one of the bigger problems in healthcare is this fragmentation. I work with a community of organizations that's focused on virtual first care, and I'd say I was talking about that tone shift. I mean, I feel like the totally virtual clinics, specialty clinics, were really focused on optimizing their service really well internally and using all the digital tools and communication platforms and remote blood draws, whatever they needed to deliver this excellent service. But there was this sort of rising over the past year feeling that we really are creating kind of a shadow healthcare system. And now that I'm seeing a wholesale shift to, we need to figure out how we can reduce the burden of primary care physicians, how we can support primary care physicians, how we can keep patients managed by primary care as long as possible, and support them. So with that, I agree with everything you said, Meredith. The tools themselves, I think, are really, really helpful, but it's the intent and the flexibility that you have within an ACO that really makes it possible. So I'll give you like one example that a colleague within the impact group told me that, you know, in as you said, number 1, number 2, and number 3 are risk stratify, close gaps in care, and escalate where needed without really driving up those specialty costs and poor satisfaction with wait times. And so, you know, take a suspected heart failure patient, cardiology office. Normally the workflow is going to be, you've got to send them out for an echo, and then you wait, and then you wait, and then that's read by a cardiologist and probably a referral to a cardiologist, and then that patient's gone, right? And we don't stop to consider what percentage of patients, probably about 80%, could be managed by that primary care physician with support. And so that sort of virtual model, you know, one of the organizations, Heartbeat Health, described to me, you know, they can now in the office get an e-consult or an embedded, you know, specialty physician on the line, get an echocardiogram done at the patient's home, send it, you know, read by a cardiologist, decide right then and there if it needs to be, you know, a new medication that can be managed by the primary care physician, with some remote monitoring, with support from case managers and care managers like Meredith talked about, or is that a transfer of care? And 80% of the time it's not a transfer of care. And what you've done now is set up, you know, evidence-based care plan. You've got backup from specialty. And I mean, you can't really do this wholesale in a fee-for-service world, because everybody's losing out on revenue, and eConsult pays 47 cents or $72 or whatever it is, right? So on the ACO model, you have the leeway to say, here are the tools we need. Maybe we need to chat. You don't get paid by Medicare for chat, but if that's what you need to do to engage that patient, you have the leeway. So I love the ACO model because of that, and the ability to apply those tools. So that's just like one example, but I'm seeing so many where the virtual care coupled with remote monitoring, coupled with the ability to collect real-time either passive or patient-reported outcomes and intervene when you need to. So it's about patients. Nobody wants to go to the hospital. You don't want to go to the ED either, right? That's at least a day of sitting there. And once you're in the hospital, it's especially if you're elderly, it could be a 6-month journey that is miserable. So this is all really exciting, and I think coming back to the ethics piece though, how do we make sure that we're personalizing this? And I think that's where the AI piece comes in. It's like, our physicians are burnout, giving them more data or more logins is going to just break the system. We're already seeing, clinicians leaving the practice. So, when we start to bring in things like AI and machine learning, we can sort of think about raising the floor so that all the routine tasks get taken care of in other settings, and then the physicians and clinicians are applying that clinical acumen at a much higher level. That is, I've never seen a lazy doctor. They want to do the medicine. It's what they don't want to do is routine soul-sucking work. And we sort of remove those barriers. So that's my soapbox, but I think there's a lot of responsibility on us to use those tools properly.
Craig, do you have thoughts there, since you're working kind of frontline with the physicians, like on kind of their feeling as these digital health tools are evolving? Kind of what are you hearing from clinicians?
Yeah, I think 3 points here. So I'm speaking as someone who barely earned a humanities degree, and you've got 2 PhDs on here, so I'm the least qualified to say this. But what I've found in working with physicians is in all providers, they're scientists, and a scientist needs data to be able to make decisions. And so if anybody has ever tried to change behavior with a clinician and you're doing it absent data, good luck. And so, having that data is incredibly important. So that's point one, is could not agree more that empowering care teams with data is critically important. Point two, and Lynette and Meredith, you both said this, and I just want to foot stomp it, is curating that data so that it's very easy to read and actionable for the physicians. As much as, and I can name on a dozen off the top of my head physicians who would love to spend 4 hours kind of looking for insights and data and playing with it, slicing and dicing it. They just don't have that time. They're really burdened with patient care, with administrative functions, with all. So we're trying to ease that as much as possible. And a way we're doing that is taking the data, ensuring that it's being packaged in a way that we get their input. How do you want to see this, and what is it that's important for you? And then we package the data in that way and give it to them. So anybody who is, may be with you may be a digital health supplier here and you have access to this data. I just beg you, please put that in good, actionable reports, because just dumping data is not going to solve. It's not going to be very helpful, and in fact, it could increase the burnout that we're seeing with providers. And then the third point, Meredith, you hit this, is putting it back into their normal workflow. So as much as you can, integrating it back into the EMR, putting it to where, if you think about the patient-physician experience in the clinic, patient comes in, a good clinician will spend time communicating face-to-face with that patient, but at some point they are going to have to interact with the EMR and either look at history, to put an order in. But so if you've got the data that's actionable for them, what they're looking at, then that's way better than having to click out and go into a Tableau dashboard that's online or with Power BI, something. Let's put it back in their normal workflow and make it simple for them to use.
Great. Well, really good discussion. We have like 10 minutes. I want to make sure we get time to get to some questions, but we did talk about equity up front. We've kind of threaded throughout this entire conversation. Like clearly there's a lot of gaps, and there's still a lot of work to be done to achieve health equity. Meredith, can you maybe talk to us about some of the ways that you've seen digital health being leveraged to kind of make inroads, especially with some of those like underserved, difficult to treat patients?
Yeah, absolutely. And that's been a really important focus for our research team over the past several years. We want to know how, Propeller programs have been implemented in different types of populations and how effective they've been. And so that's been something we've been trying to dig into by, by population, by race, by socioeconomic status, by insurance type, by region as well. And we already talked about the age question earlier today. But I would say, so we have evaluated the benefit of Propeller programs across a number of different programs, so both Medicaid as well as dual eligible programs. And really, how do we implement programs in these populations to make them successful? And in fact, when we've learned throughout the years, there have been a number of strong lessons learned early on for sure. But when we have learned that there's, with a kind of comprehensive wraparound approach that has collaborative teams working with some additional personal care, whether that's by phone call or in person, we have found that those programs can be quite successful. And so a couple of examples, we ran a program with GenCare actually in Louisville, Kentucky. So this was a dual eligible COPD population. And we had a really engaged respiratory therapist who would enroll patients and then monitor that dashboard and would reach out to them when she noticed that rescue medication signal was going up. And she would pull them in to either call them on the phone or have them come in. And she found, over 12 months, significant improvements in rescue medication use, as well as a lot of anecdotal evidence around kind of avoided acute care, so them not having to go to the ED. And it was just really powerful for her, because she could then keep tabs on the patients she was monitoring between visits, and the patients also felt like they kind of had somebody looking out for them. And so that kind of, with that personal level of care, even in a challenging population, was quite successful. And we've seen similar outcomes in Medicaid programs as well, when combining asthma educators with a primary care physician, with school nurses, for example. That kind of collaborative model has been really, really successful, even in a really high-risk Medicaid population. So I think it's, we have to understand the population that you're trying to serve, and then make it fit for that population, so that it set it up for success from the beginning. That's really critical.
Very good. And Lynette, I'd love your take on, we've talked a lot about data, and I think there's an opportunity there with digital health to maybe capture a lot of the health equity. Is like, first, before you can make improvements, you have to know where those inequities lie, right? And it feels like there's a really good opportunity for digital health to maybe capture some of that, social needs information, and some of that that critical components, like Craig's talking about, like they didn't have a refrigerator. Like, talk to me, do you think there's some opportunities, or are you seeing some digital health tools maybe being able to kind of capture some of that information and then serve it back to the ACOs so that they can be reporting that out and then knowing where to focus efforts?
Yeah, I've definitely seen, and there's so many opportunities when you do ask a patient, how are you doing and what are the barriers? That sort of process of personalizing for a patient involves asking them, like, what's going on in your life, or what are the barriers that you have? And so whether that's captured through an app or a validated, patient reported outcomes tool, or a conversation, I think the first step is actually the asking of the patient, right? So when we talk about engagement, it starts with getting to know people. Yes, the second is, I gotta keep coming back to that, building the trust that if I tell you something, it's not going to end up on Facebook or being leaked, or, I think that piece is still really, really, really critical. But let's see, I think that's the main thing, is that building the trust. And the data streams coming in from these apps are vast. And again, we have to rely on machine learning and AI. And so that it behooves us to take a really close look at those tools and continually monitor whether or not we are, perpetuating health inequities, so outcomes inequities or access inequities through these tools. I mean, you guys have seen in the news the AI and Medicare Advantage news. So being sort of up to us to keep looking at those tools to make sure that we're not just getting equitable access, but outcomes that are not disparate. And I think that there's a huge opportunity. I've seen research from Propeller as well as lots of other therapeutic areas such as migraine care, where there's very clear data that show that patients who don't have a headache specialist in their county and would have to travel, have to wait, are now getting access within 24 hours to evidence-based headache care. Same with obesity medicine. So much out there right now that, the wait, there's, I don't know how many, 300 obesity medicine specialists in the US, and we've got some very complex patient needs, lots of drugs that we really need to figure out what's right for whom, what approach. And again, how do we support the primary care physician with that evidence-based medicine? And a lot of it is, again, through building the trust with the patient, giving them access where they don't have it, and then measurement. Does that answer your capturing and reporting? Oh my gosh, I'll tell you, there's no modifier in the CPT code that captures SDOH, and wouldn't it be nice if there was? But
maybe
starting
someday.
on
Maybe. All right, well, we've had a lot of really good discussion today. We're almost at time. I want to put these key takeaways on the screen because I think we've talked about some really good stuff today. So I kind of just like putting that up there so people can reflect on that. But then I do want to bring up some questions here that are being submitted. So let's see here. Let me see. So let's see. What do you recommend? And let's see. Maybe Lynette, I'll stay with you on this one. What would you recommend as a first step to evaluating the use of digital tools for your population if you're an ACO?
Oh, that's straight back to Craig. It's where are there validated, safe, and effective tools out there that you can apply directly to your highest risk patients in a way that does not overburden your care. There's a lot, right? There's a lot of check boxes, but it's that you can deploy native to the workflow, helps you with efficiency, and has some clear outcomes and health economic outcomes. I mean, it's a high bar, guys. There are a lot of tools out there. And yeah, Craig, would you add to that? I want to hear
completely agree. It goes back to that stratification of the population, and you look at and you say, okay, we're our patients diagnosed with CHF are utilizing healthcare services 30% more than those that aren't. So what can we do to intervene in CHF early? One, it'd be nice to know, are these patients gaining weight or retaining fluid? And this goes back to you bring the clinicians in on this. Hey, what would help you to be able to bring these patients in before they go to the emergency room? This is knowing their weights every day. Great. Well, there's a lot of RPM services out there, digital services that will help us do that. So we deploy that. I think on the asthma side, just a quick case study. We had a patient who was diagnosed with asthma in the emergency room more than she needed to be. And we were able to see, start to draw a correlation between, well, she's going to the emergency room 48 hours after she visited her brother. So what's going on there? Well, brother had some type of mold. It wasn't black mold, but some type of mold in the house that was exacerbating the asthma. So those types of insights, when you start to look at the patients and their utilization and how do we reduce it, make it more appropriate, that's then where we go and look for a digital health partner. And then they check those boxes that you outlined really well, Lynette.
I love that you said, ask your physicians what would help you.
Yeah.
I mean, we forget about that, don't we?
Yeah.
When we start in with the data, ask them, how do I get visibility into my patients' lives in between the quarterly visit?
Yep.
So that I can contribute. Yeah, that's brilliant.
And just real quick, because we are at time, but I am curious, Meredith, on your take. So if if you've identified the population and this is where we want to focus on, what would you recommend as far as like vetting a digital vendors? Because there are so many options out there. What would you recommend as a couple key things to ask to really find a good partner?
Yeah, I mean, I think Craig and Lynette really put it out there well. You start with where your highest risk, kind of highest burden patients are, and then look at what's available for those conditions. I think it's also really important, especially into the future, as we see sort of aging population and multiple comorbidities. So is it a solution that can help manage actually too, like asthma and help with some mental health issues as well? Those really do influence each other. So that's going to be an increasing focus, I think, in the future. But I'm biased, but it definitely comes down to the evidence. You want to make sure that you see the evidence, and especially in those subpopulations that you are interested and need to serve. I think that's super important because one randomized controlled trial in 50 white patients from New York is not going to necessarily represent the population that you may be looking to serve. So really asking for good, diverse data, multiple subpopulations, and also the real world implementation data, because that is so critical. You can make a technology successful in a very controlled trial setting, but will it work out in the real world in a patient's daily life? I think that's also super critical.
Perfect. Well, thank you, everybody. We had other questions in there, but we're kind of at time, so I'm going to go through those and just end with a thank you to our panelists. This was a great conversation. Clearly, we could keep going. Thank you to everybody who joined us today. If you have additional questions, if we did not get to your questions, please feel free to reach out to us at Propeller Health. You can follow us on social or send us an email there at info@propellerhealth.com. I can route it to one of the panelists accordingly. And then I'm going to go ahead and bring Garrett back in to kind of close us out.
Great. Thank you guys so much. This is such a wonderful discussion, and I think we could have done this for hours and hours on end, and it would have been just as engaging. But I do want to thank you all so much for coming, and wanted to encourage you to visit the VBC exhibit hall and check out the Propeller Health virtual exhibit booth that they have there. And there's a lot of information, a lot of resources about what they're doing in the space, and you can interact with their team, and there's a lot of really cool things there. So yeah, head over to VBC exhibit hall. And that's also where the webinar recording is going to be housed. So if you needed to find it later, we will be sending out an email to everyone who registered very shortly after the presentation today. And so you'll receive a link to the recording as well as where you can download the slides. But if you needed to come back later, it will be housed in our archive library under the webinars category. So you can find it there as well. But thank you all so much for coming. If you need to reach out to us, feel free to reach out to any of the team or to myself. I'm happy to connect you. Have a wonderful rest of your day. Thanks so much.
Thank you.
Thank you.